Welcome to HEPU's 16th Think Tank, a space where policymakers, researchers, and partners gather together to reimagine health financing. The theme for the think tank was building evidence-based information to inform health financing. Dr. Lakingwira opened the session with a warm welcome to the partners from the Ministry of Health, CHAI, AFIDEP, CHAM, and academic leaders from KUHIS. As the director of HEPU, Professor Joseph Futsobengo provided a glimpse of HEPU's main pillars: capacity building, research, decision science, and supporting national policy with evidence. HEPU is not working in isolation. It's about training experts, supporting ministry priorities, and coordinating platforms to facilitate necessary conversations in response to Malawi's health issues.
Achievement. So far, 2 MOH members sponsored under the Transi Studentship Program to do masters in economic evaluation. 6 fellows recruited, health economics and policy, and one of the largest in sub-Saharan Africa. When we went to Kigali, we were noted to be the biggest health economics unit in sub-Saharan Africa, which was a surprise to many. We also we're doing a directed facility funding, financing, training, and transmodeling short courses. So I would like to acknowledge our donors for their support and for the ministry for working with us.
Associate Professor Eric Umar, on behalf of the Executive Dean of SOGAF, celebrated HEPU's quarterly think tanks. With donor support shrinking, he urged that Malawi needs to act fast, emphasizing the importance of the country having a comprehensive, context-aware financing strategy, one that turns every kwacha into real, measurable impact.
The 16th think tank meeting comes, as you all recall, that in the last think tank, we initiated a discussion on health financing where we discussed on HIV/AIDS sustainability amidst the US government funding withdrawal. So today, it's a continuation with this discussion, and also on initiative, evidence for effective implementation of the health financing strategy. If there's one thing that actually our country probably is in a way struggling with, is really having funds that can actually push most of these very brilliant ideas that we would have. So this is really very crucial. We see this meeting not just as a discussion, but as a vital step in translating academic insights into tangible improvements for Malawi's health system. We are, as a school, also very excited looking at the agenda that's health financing, progress metrics discussion. This is important to track progress of health financing reforms.
Dr. Gerald Mantalo, the director of the Department of Planning and Policy Development within the Ministry of Health, stated that while donor funds are shrinking, the process to achieve universal health coverage doesn't have to. He referenced the Health Fund, which was once an idea but is now a policy reality. His message was, if Malawi is to succeed, we must speak the same language: ownership, integrity, and purpose.
I'm just happy that things that we have been discussing are now actually becoming realities. And that just demonstrates the power of these kind of meetings, because it's actually through these think tanks or just people that are involved in these meetings, just sitting together, brainstorming, that is bringing us to where we are. And that actually takes me to the importance of just believing, you know. I know there's so many narratives that are out there. When you read the news, I think I was reading the BBC another day, and they were like, American aid withdrawal, so many millions are going to die in Africa. I'm like, who did these estimates? You know, I just feel like we have to create our own narrative, you know, about the situation. We shouldn't let other people create the narrative for us. Let's create our narrative about the situation that's in our country. And that's where I really believe that as a people, as thinkers, as scientists, we think about what we need to do, but we also must believe about what we are thinking, about our strategy. Let's feel free to contribute. There's a very important subject at hand today. I just really think about the financing, how things need to work. There are quite a few reforms, but now we sort of get into the details of how do we actually make these things really work? How do we make them consistent at actually the different levels across government, private sector, private not-for-profit? How do we make these ideas consistent, make sure the policy is coherent across different dimensions?
Economist Atupele Zinkambani unpacked the Health Financing Progress Matrix, a tool to assess how Malawi's health financing system aligns with the goals of universal health coverage. The study revealed we have a lot of work to do. The proliferation of funding streams and inadequate coordination has led to a fragmented system. However, Ms. Zinkambani noted that this could also serve as an opportunity. With strong stakeholder engagement and strategic documents such as the Health Financing Strategy 2023 to 2030, improvements can be made to the health financing matrix.
The assessment of Malawi's health financing system highlights both the strengths and critical gaps that need to be addressed for sustainable and equitable health financing. Like I said, the health financing policy, governance, and public health programs are relatively well established, demonstrating the government's commitment to structured healthcare financing and preventing health measures. However, the system still faces significant constraints in revenue raising, calling on funds, provider payments, and equitable access to healthcare systems. So we need to focus on improving healthcare quality while continuing to strengthen financial protection as well as efficiency and equity.
Dr. Celia Woodfill and Ms. Pemperompamba shared findings from governance and financial autonomy research in 40 faith-based facilities, commonly known as CHAM and IHAM facilities. Their presentation demonstrated how strong governance boards in CHAM and IHAM hospitals enhance both financial performance and service delivery. Health centers lacking this structure fall behind. Their research recommended a hybrid model with central oversight, with dedicated boards at the facility, standardized indicators, and stronger local engagement.
We reviewed governance and management arrangements in faith-based health facilities, CHAM and IHAM facilities in Malawi, to understand the implication on financial management, but also service delivery. This study is policy relevant, but also very timely, especially at a time where Malawi has just rolled out the Malawi Direct Facility Financing. The insights from this study we're hoping will inform the DFF and institutionalization and how best it can be implemented for good healthcare outcomes.
This is what we learned about the proprietors, that the level of engagement varies a lot. At the facility level, varies by proprietor. Some of them come to the facilities regularly and others rarely. Again, the financial oversight and management roles vary by proprietor, how engaged they are in the financial side of things, or whether they just delegate responsibility to the board. We also found that both an influence of faith-based values and the funding sources can influence the governance and service delivery in these facilities. Almost all the facilities had boards. The majority reported of the hospitals had dedicated boards. Hospitals showed greater financial autonomy than health centers. In health centers, neither facility management nor HCMCs had much involvement in the development of the annual budgets. And most facility in charges assume critical administrative responsibilities without any formal documentation or structured guidance.
Dr. Dominic Nkoma proposed a unified financial model, providing facilities with real budget control, enhancing digital financial systems, and aligning everything with the national strategy.
Our per capita has stagnated at $40, and even within that, majorly supported by donors, 55 to 60% over the past decade or so. And government expenditure total has remained within 15% during that period, $15 per capita over that period. And there's been struggles, of course, on the government side to raise the or to fund their sector to the Abuja target. But even if they gave their sector the money at Abuja target, it still doesn't shift the nominal amounts that's needed. Just for reference, the WHO, I think the recommendation has been shifted upwards, but at least it's been $68 per capita as a minimum recommendation for benefit packages. And so at $40 per capita, total health expenditure, this is gross underfinancing of the system. And the HSSP3 projection suggests that this would remain unchanged with the per capita before the donor free CAS was projected to marginally get to somewhere around $50 by 2030. And we know that estimate needs to be revised given what we're seeing with donor funding. So essentially, we then need to be thinking about how we raise funds internally. There's been a lot of work on efficiency, but efficiency also has limitations that you can only optimize what you have. Given that our major problem is a problem of absolute numbers, so how we move from the $40 when already the landscape suggests that we must be worried that maybe the per capita could be going down.
The last presenter, Mr. Maziko Matemba, chairperson of the International Coalition on Health Financing Advocacy, reminded us that governments cannot do it alone. Actors play a crucial role in advocacy, accountability, and driving reform. With over 400 health advocates across Africa, Malawi has the potential to do more. He called for an increased community engagement, improved tax system, and a reallocation of at least 1 to 2% of the national budgets to healthcare.
Health should be top on the agenda in the region, because if you don't tackle health, then we'll be in trouble. And also we have seen the US government reduce support what is happening in the country at the moment. Some districts are registering high instances of new infections in HIV. Blantyre being an example. If you go to Blantyre now, talk to Dr. Kawazi, he'll tell you that the figures are going up. It's worrisome. So funding becomes important. So in terms of way forward, we still want to engage and also increase expenditure. We allocate around 1% of the budget towards the health sector that is in the Southern Africa, so that we can mitigate the effect of withdrawing of resources. But also government need to maintain and deliver essential services, but also make sure that we're still working with the ministers of finance and other stakeholders to make sure it's done.
The plenary, moderated by Dr. Dominic Nkoma, highlighted 10 critical themes, 4 of them being good governance driving better results, budget control must align more closely with service delivery, informal payments remaining a blind spot, and communities not just being passive beneficiaries. They are stepping up, building facilities, and asking for more clarity. Closing the session, Dr. Mantalu urged stakeholders to see health financing through a wider lens, one that intersects with education, agriculture, and economic development. Health isn't just a ministry issue, it is the foundation of human capital. Malawi has the tools, it has the minds, and it has the will. This is more than policy talk. It is the start of a movement where data leads, people own, and actions follow. Thank you for joining the 16th Think Tank, where we think together. Until next time.